Hello everyone. So we will be discussing about the fluids and electrolytes imbalances and management. So this is very important in regards to managing patients who have different metabolic condition or other disease processes that might develop fluids and electrolytes imbalances. So the learning objectives for this would be to understand the physiology of the different fluids and electrolytes, and to know by heart the different laboratory values and radiology workups that need to be done to clients who have fluids and electrolytes imbalances as part of the diagnostic studies. And of course, don't forget to apply the nursing process in the fluids and electrolytes imbalances and management. Now, remember when it comes to NCLEX-RN focus and how you will be tested on these concepts is you have to know the normal laboratory values. Okay, so you really need to create a post-it in your, whether it's in your room or in your study area, where you can memorize all the lab values because it's very vital, and also the common clinical manifestations of your patients. So I'm not asking you to memorize each and every clinical manifestations that you would see, but at least have at least 3 to 5 most common clinical manifestations when your patient has possible, fluid and electrolyte imbalance or imbalances. And also how to formulate priority nursing diagnosis based on what you see. And you have to know your role as a nurse on what you can do and what you cannot do based on what's going on with your patient, and what you can delegate, because you cannot do everything on your own. You have to know what to delegate to LPN, to LVN, to UAP, and when to do head-to-toe assessment versus focus assessment. So again, it varies per patient. And again, if you don't know the patient and you don't know exactly what's going on, then you have to do head-to-toe assessment. But if you already have an idea on what's going on with your patient, then you have to do focus assessment. Okay? And we will discuss also different interprofessional and nursing management. Now, when you look at NCLEX-RN test plan, and this is based on the 2019 NCLEX-RN test plan, is all of this we will discuss in these concepts. So as you can see, majority of the questions will be coming from management of care, and second would be pharmacological and parenteral therapies. And some of this, as you can see here, physiological adaptation will also be asked. Now, as you can see, I highlighted here the test plan, okay? And as you can see, you really have to know how to manage patients who have fluid and electrolyte imbalances. Now, just an introduction is that over, the lifespan, as you can see, from preterm, the percentage of body weight is, 80% would be water for preterm. For neonates, it will be about 70 to 75%. For a child, it will be up to 70% or more. For an adult, it will be about 60% for male, and for women, it will be about 50% up to 60%. And again, as we became an older adult, as you can see, it drops to about 40%, and that's for male, and for female be about 40% also. Okay, so as you can see, over a lifetime, our water component in our body decreases as we age. And as you can see here, when it comes to fluid compartments of the body, and you guys learned this way back in pathophysiology, is there's about 3 liters of plasma. And as you can see, this is the plasma. Interstitial fluid is about 10 liters, as you can see. And intracellular would be 28 liters. Okay, this is intracellular, this is interstitial. Okay, and this is very important to understand where plasma is, where interstitial fluid compartment is, where intracellular fluid compartment is, because when we discuss management and looking at clinical manifestations, these concepts are very important. And in here, this is another image of intracellular, interstitial, and extracellular. Okay, so intracellular means it's inside the cell, while extracellular means outside the cell. So outside the cell, you'll find interstitial fluid compartment and also the plasma. This is another image of major fluid compartments that I showed you earlier. So as you can see here, this is intracellular fluid compartment, and again, it's inside the cell. And interstitial fluid, about 12 liters. As you can see, you will see here the water and the different electrolytes, and there are like shifting from intracellular to extracellular and vice versa. And we have here the plasma, which is about 3 liters. So as you can see here, majority of it's coming from the intracellular fluid compartment, which is 40% of our body weight, and extracellular is about 20% of our body weight. Now, it's very important in this concept that you know how to calculate fluid gain and loss. Okay, so in here with your patient, when you're taking their intake and output, is remember that 1 liter of water weighs about 2.2 pounds, which is 1 kilograms. So in short, if your patient, let's say, gained, let's say, 3 kilograms, then you have to know that it means that they gained about 3 liters of water. Okay, so that's what it means. And this is very important, also an indicator when you know if your patient had volume loss or gained a lot of weight due to this water component or water retention. Now let's look at the different diagnostic tests. So again, you've learned that it's very important for us to perform, history and physical examination to our patient. We have to ask them, what's their past medical and surgical history, what are the medications they're taking, whether it's home medications that are prescribed or whether it's an over-the-counter type of medications. Now, again, I mentioned earlier, as a nurse, we have to perform history and physical. We have to perform head-to-toe assessment or focus assessment depending on what's going on with your patient. You have to perform vital signs, okay, to your patient, checking their blood pressure, temperature, and also, what specific IV therapy the patient needs, whether it's peripheral, IV insertion, or central line, depending on what's going on with your patient. Now, other part of diagnostic tests, we have here CBC, complete blood count, and as you can see here in this list, you can see in CBC like hematocrit, hemoglobin, platelet count that you need, that will help you identify if this patient lose a lot of volume based on, let's say, your patient, had a trauma and bleed a lot, then you would know by looking at their hemoglobin and hematocrit. Or if your patient is dehydrated, right, you would look at the hematocrit. Now for BMP, or basic metabolic panel, or CMP, which is the complex one, which have a lot of electrolytes there, is you would need, of course, test tube, green test tube for that. And you have to check also magnesium and phosphorus. Now, looking at the levels, these are very important. You have to know the normal values. So like for sodium, it's 136 to 145. In other textbook, it's 135 to 145. And again, please memorize all of this. You have to know it because this will give you a heads up if your patient has an electrolyte imbalances that you need to address. And also, we ask our patient for a urine specimen to check urine specific gravity, right? In here, urine osmolality. We also have to check their bun and creatinine because that gives you a heads up, especially with creatinine if your patient has renal insufficiency, secondary to, let's say, dehydration. Okay, so let's say you saw that urine specific gravity is very, very high, then that tells you that this patient might be dehydrated. That's why everything is concentrated. Okay. Now, this is an example of what would urinalysis results look like. Okay, this is the urine specimen. You send it to the lab for urinalysis. And here are the things that you would see, like bilirubin, blood, glucose, ketones, leukocytes, nitrite, specific gravity here, and vitamin C. It depends on what we're checking. But remember, we're more concerned of the specific gravity for fluids and electrolytes imbalances. Now in here, I've mentioned earlier about urine specific gravity. If it's very high, then it indicates that your patient is dehydrated or has fluid volume deficit. Okay, same thing with urine osmolality. If it's very high, then it means that your patient is dehydrated or has fluid volume deficit. And it will be opposite for patients who have fluid volume overload, where their urine specific gravity will be low. And same thing with urine osmolality here, their urine osmolality will be low. Now, other diagnostic tests here, we have serum osmolality. So when we say serum, it means that the sample was taken from the blood. So for your patient who's dehydrated, of course, everything is concentrated. Then the serum osmolality will be high and it will be low for fluid volume overload. Now, other diagnostic tests, we have here chest x-ray. And chest x-ray, it will tell you if your patient is developing fluid volume overload in their lungs. So, of course, this is what normal looks like. And of course, you can see the silhouette of the heart. And as you can see on letter F, you can see this is worst because you would know that there is no good aeration and ventilation in the lungs. Okay, this means that maybe your patient has pulmonary infiltrates. That tells you your patient has a fluid volume buildup. Okay, compared to letter A. Letter A is a normal finding. Letter F is an abnormal finding. Okay, now another diagnostic test would be 12-lead EKG. And again, if your patient has a potassium imbalance, magnesium imbalance, then you might see some arrhythmias, problem in the heart rhythm. So that's why we need to perform 12-lead EKG. Now, IV therapy. Okay. Now, when it comes to IV therapy to our patient, it depends on what they need. Now, we have here different types of IV access. We have peripheral and we have central line. Now, reminder that when a client is dehydrated or has fluid volume overload, it is very hard to start a peripheral IV because you might not see veins if they are dehydrated. If they are having fluid volume overload, then it's still a hard stick because they have a lot of edema and it's kind of hard to locate their veins. Okay. So here are the different catheter sizes. We have 24 grams, we have 22 grams here, 20, and as you can see, 18 gauge is the biggest, okay, that we really want our patient has, okay, that's why. And as you can see, it's color-coded, okay. You don't have to memorize the colors, but again, in clinical practice, it's really helpful for me, especially if the nurse did not chart anything on what is the catheter size. So if I saw it's green, then I know it's 18 gauge. If I saw that it is light blue, then I know it's a 22 gauge. Okay, so it really helps with the color coding, but again, I'm not asking you to memorize it. Okay, just know there are different sizes, and if you can start 18 gauge, that's perfect. If you cannot, then start small. Okay, you can go to 22 gauge or 20 gauge to be able to start an IV therapy to your patient. And of course, we have here an IV pump, and it varies per facility. So when you go to clinical, you just have to, ask your clinical instructor to orient you on how to use one. At least you're familiar with it. Okay. Now we have here a peripheral IV. As you can see, it's well dressed. Okay, and of course you have to put daytime and initial. And here are the different veins. Okay, here we have the cephalic vein. We have here the basilic vein. Okay, there are some accessory cephalic veins there. That, again, you have to use veins to be able to administer an IV fluid. Here are another IV access. These are central venous access devices. So we have here triple lumen catheter, as you can see in here. We also have here PICC line with 2 lumen. Okay, there's a red port. This means you can draw blood here. There's a purple port, or here you can administer IV fluids, TPN, you can do that in there. Okay, so let's discuss different IV fluids. So you've learned from fundamentals of nursing, different types of IV fluids, and in your other classes. So I want you to remember them by heart. And I know it's kind of hard, but remember for isotonic, your baseline number is 0.9. And I'm gonna be going back and forth from this slide and to another slide. So I want to show you the list of isotonic. So remember, I want you to remember 0.9. Okay, that's your baseline. Now, anything below 0.9, that will be hypotonic. So you will notice that anything below 0.9%, that would be hypotonic. So you see 0.45, 0.33%, 0.2%, okay? That is hypotonic. And anything beyond 0.9%, that will be hypertonic. So you will notice that 3% is higher than 0.9, and that is hypertonic. You see, there's 5% sodium chloride. Okay, now you will notice to another challenge of the students. How about dextrose? Now for dextrose, your baseline number is the 5%. Anything below 5%, that is hypotonic. So here you see 2.5%, that's hypo. And anything beyond 5, that is like D10 water, that's hypertonic. So I hope my tips regarding this would help you to remember them, okay? Because it's very important when you're trying to answer the management. Now I'm gonna go back to the previous slide. So as you can see here, that there are effects of water on red blood cells. So here are our red blood cells. As you can see, when you administer an isotonic solution, it doesn't seem that it make any significant changes in the red blood cells. However, when you administer, like for example, hypertonic solution, for example, a 3% sodium chloride, it can cause it to shrink. Okay, so as you can see, it will look like this. That's why when you're giving hypertonic solution to your patients, you really have to be careful, because you don't want to give too much, that it will really shrunk the red blood cells. Okay, because remember, we need our red blood cells to be able to supply also oxygen, throughout the circulation. Now, In the contrary, when you give hypotonic solution, as you can see in here, it can cause the red blood cell to swell. And this is also not a good effect. So when you're giving hypotonic solution, whether you're giving a 0.45% of sodium chloride, let's say for a long time, you have to be careful because it can cause that swelling. And again, that can affect the oxygenation in the body. It can affect on, how, the brain, the brain will swell. There's a tendency and your patient can have seizure. So again, when you're giving different IV fluids, you just have to make sure you know what will be the effect of giving that to your patient, to promote patient safety. Now, this is just to show you the cations and the anions in intracellular fluid compartment and plasma. And we will talk about on the following slides the different types of electrolytes and imbalances and how do you manage them. So as you can see in the plasma, what you would see is majority of it would be the sodium, okay, few potassium, calcium, and magnesium, and you can see other electrolytes in here too, and also protein. But in the intracellular side, you will see majority of it would be potassium, as you can see in here. Okay, and a little bit of component of sodium, magnesium. Okay, some phosphate in here, a little bit of protein, bicarb, and chloride. Now, let's talk about sodium imbalances. And again, you have to know the normal level. Earlier, I showed you 136 to 145, but for exam purposes, we'll be using 135 to 145 MEq per liter. Remember, when you're asked about sodium imbalances, remember that your priority is brain function. What does it mean? So it means that most of the time when patients have sodium imbalances, they have a tendency to have seizures. So promote patient safety. So now, typically, it is associated with, osmolality. And remember, our sodium is very important in maintaining the volume and concentration. It has a function in transmitting nerve impulses. That's why when your patient has sodium imbalances, they have tendency to have seizures. And as you can see here, muscle contractility also. And if your patient has sodium imbalances, it can also affect the acid-base homeostasis. So that's why when you check the arterial blood gas, you might see some abnormality in there. Now let's talk about hyponatremia or low sodium. As you can see here, your priority would be risk for seizures. So your patient, their risk for injury, you need to put them on some safety precautions, like for example, close to the nurse station, side rails up, okay, but only 2 side rails, okay. And the most common conditions that cause hyponatremia, and I listed it in here, would be heart failure. It can cause dilutional hyponatremia because when your patient has heart failure, they have fluid volume overload and the sodium on it will be diluted. So that's why it's called dilutional hyponatremia. Okay, it's either your patient has high extracellular fluid or low extracellular fluid. Okay, and how would you know the difference between the two? So let's talk about it. So with neuro, they will have, of course, altered level of consciousness. And as a nurse, what you do is you monitor it, you compare what your baseline is when you get them or when you admitted them, and you have to do fall precautions. And what I did in here is I listed most commonly used nursing interventions in NCLEX, so you have to be familiar with this. And also you have to put them on seizure precaution. Okay, so I put some in here, and of course if your patient is having seizures, you have to give them lorazepam IV push, and that's for acute seizures. Okay, now you will know if your patient has high extracellular fluid by looking at their blood pressure. So when you notice that the blood pressure is high, then there's a tendency that there is high ECF or high fluids. Okay, if the blood pressure is low, then it means there is low extracellular fluid with low sodium. Okay, so again, of course, for you to know if your patient has low sodium, you have to check the blood of your patient and look at the level. Now, this is lorazepam, and I want you to think of, let's say, the healthcare provider's order is to give lorazepam 1 milligram IV push PRN for seizure every 4 hours. Now, the question is, how many ml do you think you should give to this patient? So I'll give you a minute to think about it. So think it through. So as you can see here, the given vial is a 2 milligram per ml. So it means in every ml there's 2 milligrams. So if you only need 1 milligram, then you only need 0.5 ml, right? So I hope you got the same answer. So now let's look at cardiac. So if your patient has hyponatremia, you want to make sure you monitor their vital signs. You want to check their heart rhythm because there's a tendency this patient might have arrhythmias also, and their intake and output, especially if we're talking about high ECF, low ECF, or also known as high volume, low volume. You want to know how much this patient ate and how much this patient, had your urine, their urine output. You want to know that. Now, if the given case scenario, let's say this patient has high volume but low sodium, you want to give them diuretics. Now, you all know diuretics can make the patient urinate, right? So you want to be careful also in giving them, okay? So if you want to be a little bit sensitive with it, so you can start giving them potassium sparing if you think that their potassium is a little bit in the low side, or whether it's normal but in the low side, you can give that. Now, you might be thinking, why not loop diuretics? You can also give loop diuretics. I'm not telling you not to, okay? You can either give furosemide or bumetanide, but it's just that you have to make sure you're careful not to be eliminating too much sodium. So you can give it, but with caution, okay? And remember, you've learned this in pharmacology that before you give diuretics to your patient, you want to make sure you check their BUN and creatinine, okay? And if the level of potassium is low, I already mentioned earlier, you can give potassium sparing, like spironolactone, the most commonly used, triamterene, amiloride, you can also use that. Now, since we're talking about low sodium, you can give something with sodium, like hypertonic solution, like 3% sodium chloride in here. You just have to be careful in giving it, okay? Now, if the given case scenario is that your patient has low sodium but with low volume, so this is the time you give IV fluids. And again, the safest IV fluid that you can pick for patients who have hyponatremia is isotonic. Okay, you can start with isotonic solution, but remember to monitor your patient for possible fluid volume overload. Okay, so you have to monitor their respiratory rate, their breathing pattern, their O2 saturation. So here are the loop diuretics. So probably you're familiar with it. We have furosemide, we have bumetanide with their specific volume and how many milligrams is has each vial. This is the sodium chloride, the isotonic solution that we commonly give to our patient. And again, monitor for possible circulatory overload. Okay, here we have lactated ringers. This is also isotonic, but The problem in here, I would say, not problem, I would say a complication that you have to watch for is that it can cause high calcium and high potassium. So be very careful when you're using this IV fluids. It's just that when you're using it, it's commonly given to patients who have, who had gunshot wound, traumatic brain injury. We commonly give them lactated ringers solution. Now, for respiratory is, of course, for our patient, you want to make sure you check their lung sounds, respiratory breathing pattern, otosat, ABG, okay? And of course, if your patient has low sodium but high volume, as you can see here, you might see that they are having labored breathing, having a hard time to breathe. So you just put them on semi to high Fowlers and, provide them oxygen. Okay, but if your patient has low volume and low sodium, then you want to make sure you check the blood pressure. If it's low, then give fluids, and something that can help them too is to put them on reverse Trendelenburg, okay, position, so that you are redistributing or creating a fluid shift that will help the patient. Okay, now, let's move on to hypernatremia. So this is the opposite of hyponatremia. So again, your focus is that this patient will be at risk for seizure. Okay. And here are, again, same priority. Look, risk for injury, risk for seizure, so safety precautions. Okay. So again, the most common cause of this is fluid volume deficit, where your patient has high sodium but low volume. And you will notice here that when you look at nursing interventions, we're pretty much doing the same thing. Okay? You will notice that on this slide. And when you look at the intervention here, even with, let's say, low volume, high sodium, you're doing the same thing in here. Okay, just want to show you that. And same thing with respiratory. So as you can see in here, even with high sodium, we can still give isotonic solution. However, again, you want to make sure that you double check the sodium level of the patient, because if the sodium is too high, secondary to dehydration, then you can give this, because again, normally it's part of compensation of the patient when they're dehydrated, wherein they concentrate everything, but again, you have to monitor them very closely. And I also put here lactated ringers, and I discussed that earlier on what this one is and what you have to watch for. So let's move on to potassium imbalances. So for potassium imbalances in here is your focus now would be heart function. So if for sodium, your focus is the brain, for potassium, your focus is the heart. And potassium is a major intracellular fluid cation. It's very necessary to heart contraction and also for the resting membrane potential of nerve and muscle cells, and very important in cellular growth. And as you can see, like with sodium, it can also affect the acid-base balance of your patient. Now, there are different sources of potassium. As you all know, we have protein-rich foods, fruits and vegetables that are rich of potassium. There are also salt substitutes, and you all know for patients who have cardiac condition, we don't want them taking some salt substitutes because they are high in potassium. And if you're giving potassium medications to your patient, that also put them at risk to develop hyperkalemia. And again, to stored blood, the blood transfusion that we give, they're commonly have high potassium component. Remember that potassium is regulated by kidneys, because when there is an excess potassium in our blood, then of course it will be, some of it will be excreted via kidneys. And that's the reason why when your patient has kidney failure, that they can have hyperkalemia because the kidneys are unable to excrete the excess potassium. Now let's look at hypokalemia. So hypokalemia means there's low potassium in the blood. So again, the most common cause of this is giving diuretics to your patient, especially when you're giving loop diuretics like furosemide, bumetanide, that can cause hypokalemia. So again, as you can see here, I only put cardiac because that's our focus for potassium imbalance. So for cardiac, what you would see if your patient has hypokalemia is the presence of U wave in the EKG. So instead of seeing PQRST, you will also see U, okay, U wave. And that tells you that this patient might have hypokalemia. So again, you want to make sure that you check their blood pressure, the heart rate, because again, our focus is cardiac. You want to check the potassium level of the patient, or if the patient's taking other drugs like digoxin, that might also affect and can have an interaction with hypokalemia because that can predispose them to develop digoxin toxicity. And you want to check their 12-lead ECG, their baseline. Okay, and again, if your patient has low potassium, then you give potassium. And remember, this is a very common NCLEX question that you do not push potassium. Okay, you can give potassium via PO, you can give it rectally, or you can give it as an IV infusion. Now, as you can see here, these are the ECG effects of potassium. So this is what the normal looks like, normal PQRST. And again, U wave may be present, but it's very shallow. It's not very prominent compared to a patient that has hypokalemia. Because if there is a hypokalemia, you can really see here an ST depression. And when you look at the U wave, it is very prominent in here, as you can see. And there's a shallow T wave in here. And you will see that there's an abnormality in the PR interval in here. It's prolonged. Okay, while to a client who has hyperkalemia, you will see everything is at peak. Okay, you can see that QRS is widened, the ST segment is depressed. Okay, and you can see a tall peak T wave in here. Okay, so again, by looking at the ECG of your patient, you will already know what's going on or might be going on to your patient. So again, this is what PQRST looks like. And again, you can do a 5-lead ECG, and this is what the cardiac monitor looks like. And these are the electrodes that you can use, and this is the placements of the electrodes. So the right arm, left arm, okay. In here, you put the green, you put the red in here. So it's color coded, okay. So the grass, okay, this represents clouds, okay. So as you can see here, white, black, green, red, and here you will put the brown. This is the placements for 12-lead ECG. So just to show you the placement. So when you go to clinical, if you will have an opportunity to perform 12-lead EKG or at least observe someone doing it, take a look on how the placements are, because this is very important when you start practicing as a nurse. This is a routine procedure to your patient, especially if they have arrhythmias or new onset of arrhythmias that the cardiologists need to know. Okay. Now, let's move on to hyperkalemia. So again, your focus here is cardiac. Okay, so you can put here cardiac on your notes. And the most common cause of hyperkalemia is when you give too much potassium to your patient, or if your patient has kidney failure, then they can also have hyperkalemia. So again, your focus is here is cardiac, and little arrhythmia would be your patient can have asystole, because a very high potassium can stop the heart. Okay, so what I did in here when it comes to medications is I put them on based on the level that's given to you. So if the level of the potassium of your patient is about 5.1 to 5.5, then you can give thiaxalate or sodium polystyrene. And you want to make sure that your patient has the ability to eat or drink, because again, this is given rectally, so your patient will poop. But if your patient did not eat for like 3 days or 5 days, then it doesn't make any sense to give it, because your patient will not poop. And you want to check the bowel sounds of your patient. Okay, or you can give diuretics like furosemide. It's just that you want to make sure you check the bun and creatinine, and you want to check if the patient is also taking digoxin. Okay, because again, digoxin, and then let's say the potassium suddenly drop, then that predisposes your patient to develop digoxin toxicity. Now, if the potassium level of your patient based on the laboratory result is 5.6 or higher, then you need a stronger medication like dextrose 50 IB push and 10 units of regular insulin. It's just that you have to watch for their blood glucose level. Another thing is calcium gluconate. You can give that via IV push, but you want to make sure you give it slowly because it can drop the blood pressure. Temporary dialysis is also needed, because the thing with temporary dialysis, it can remove excess potassium. And you want to avoid foods that are high in potassium. Okay? And there's a long list of foods that are high in potassium. And you might be familiar with some of that. Okay? So like for example, with bananas, that's very common: avocado, orange, spinach, sweet potatoes, yogurt, beans, cantaloupe, raisins, beetroot. Those have high potassium components. So you want to make sure you educate your patient not to eat them and to avoid them. Okay, again, I showed you this earlier, that if your patient has hyperkalemia, they will have tall peak T wave and widened QRS and the ST segment depression in here. This is what the normal looks like. And again, to administer the sodium polystyrene or thiaxalate rectally, this is how you position your patient to administer it. Okay? This is what the dextrose 50 IB push looks like. So you just remove this yellow cup in here, remove the yellow cover in here, and then connect this to this for you to be able to administer it via peripheral IV or central line. And to administer it, remove this yellow in here and connect it in the IV port. Okay? Or temporary dialysis, as I told you. These are the list of foods that have high potassium that you need to educate your patient with. Now let's move on to calcium and phosphorus imbalances. So for calcium, this is the normal level, 9 to 10.5 milligrams per deciliter. And for phosphorus, it's 3 to 4.5 milligrams per deciliter. So I put them both because their relationship is inverse. That means that if the calcium is high, the phosphorus is low, and vice versa. So let's start with calcium. So calcium is very important in the formation of the teeth and bone. It's also important in blood clotting and transmission of nerve impulses, heart and muscle contractions. Now, remember that calcium can be obtained from our diet. However, we need vitamin D for it to be absorbed. So it's present in bones and also plasma. And again, with calcium, it can change the pH. And again, it has an effect to the serum albumin. Now, remember that with calcium, it is controlled by parathyroid hormone, which, when our blood doesn't have enough calcium, is what happens is the parathyroid hormone will be released from the parathyroid gland, and what happens is it increases the release of calcium from the bone. That's why you can see here increases bone resorption. It increases the absorption of calcium at the gut, and renal tubule will reabsorb calcium. While if the calcium level in our body is too high, then what's going to happen? Calcitonin will be released, and it will increase the deposit of calcium into the bone, and it increases renal excretion of calcium and decreases GI absorption. So as you can see here, that our body is magical, that it does this to make sure that everything is within normal range. So for phosphate, this is the primary anion in ICF, and it's essential to function of muscle, RBCs, and nervous system. So with phosphate, it's very involved in acid-base buffering system. So that's why when your patient has phosphorus imbalances, you will also notice that ABG results may change, and calcium level might also change. And as you can see, it's very important in the production of ATP or energy. Okay, and also has something to do with our glucose uptake and metabolism. Another thing is that it can be affected and controlled by parathyroid hormone and kidney function. Now let's look at the hypocalcemia and hyperphosphatemia. So as you can see here is, again, if your patient has this, your focus is more on coagulation, because calcium has a very important function in blood clotting. You want to check their DTRs, or deep tendon reflexes, cardiac function, and level of consciousness. And remember, patients who have calcium and phosphorus imbalances, they are at risk to develop seizures. And for neuro, when a patient has calcium and phosphorus imbalance, they are at risk for injury. So as you can see here, we're using, again, safety precautions, seizure precautions. And remember, your patient will need a peripheral IV or central venous access device. Now for cardiac, we will notice that their heart rhythm may change. And again, you want to make sure you monitor the 12-lead ECG, blood pressure of the patient, heart rate, coagulation studies, because again, calcium has an effect on blood clotting. So technically, we're checking all of this because of the calcium, okay? Not necessarily because of the phosphorus. So respiratory, remember, your patient may develop respiratory alkalosis when they have hypocalcemia or hyperphosphatemia. So this means that their pH will be high, their CO2 will be low. And remember, your patient may need oxygen. Now for musculoskeletal, you might see that your patient might have Trousseau sign. And this is when you put the blood pressure cuff in their arm, they will have carpal spasms. And when you tap the cheek of the patient, they will have Chauveau-Stich sign when you tap the cheek or facial nerve. And you will notice too, when you check their deep tendon reflexes, they can have hyperreflexia, wherein when you check the biceps, triceps, Achilles tendon reflexes, it will be hyperactive. Now, medications. So if your patient has low calcium, then you want to give calcium. So that's why you can see here, you want to give calcium by mouth, but make sure you have vitamin D. You can give something IV, but very slowly, because it can drop the blood pressure you want to educate your patient about increasing calcium, source of foods in their diet. And you want to make sure you put your patient on bleeding precaution because they have tendency to bleed if their calcium is low. And be cautious when you're administering something that is anticoagulant or blood thinner like warfarin. Okay, now when it comes to hyperphosphatemia, okay, let's say you check the calcium, it is low, and you check the phosphorus, it's really high. Then this time you want to give phosphate binders. So what it does is when you give calcium carbonate or sevelamer, is the excess phosphorus binds to it, and then your patient will defecate that excess phosphorus. Okay, and remember to avoid dairy products. Now let's switch. Earlier we talked about low calcium and high phosphorus. Now this time we'll be talking about high calcium and low phosphorus. When you look at the NCLEX-RN focus here, it did not change. So we're pretty much doing the same thing. And you will notice that here in neuro, in cardiac, in respiratory, and musculoskeletal. However, you will notice that for respiratory this time, your patient will be at risk to develop respiratory acidosis. Okay, they will be hypoventilating and they need oxygen. While for DTRs, they will have hyporeflexia. Now, for the treatment for high calcium, is this time we want to give diuretics to them, loop diuretics or potassium sparing. But remember to make sure you check hydration status, because if your patient is already dehydrated, then you don't want to give something that will make them urinate more. Okay, so you want to make sure you check their blood pressure, you want to check their kidney function, and if they have fluid volume deficit plus high calcium and low phosphorus, you want to give them isotonic IV fluid. And this time, you want to put them on clotting precautions. So you want to watch out if they're having symptoms of pulmonary embolism. You want to check if they're having chest pain and shortness of breath, or any changes in their level of consciousness wherein they are at risk to develop stroke. Okay, so for this type of patient, we want to give them enoxaparin, and that's a prophylaxis because if they have tendency to clot more, then you want to give this as prophylaxis. Now, if their phosphorus is very low, then you want to give phosphorus, right? So we give them biphosphonates. Examples of this are zoledronic acid or pamidronate. But remember, pamidronate, you might see that to patients who have cancer. Okay, now if any of these two are not working, then we will give them denosumab. Okay, and dialysis is also an option for this type of patients. Now let's move on to magnesium imbalances. And for the magnesium, the normal is 1.3 to 2.1. And in here, remember, magnesium is a cofactor in enzyme for metabolism of carbohydrates, and it's required for DNA and protein synthesis. It's very important in blood glucose control, blood pressure regulation, and needed for energy production. And as you can see here, it has an important function in cardiac. So that's why when patient has magnesium imbalances, you will also notice arrhythmias to them. And the thing with magnesium, they're absorbed in GI tract and excreted via kidneys. Okay, for low magnesium is, again, our focus is cardiac for magnesium. Now you will see arrhythmias like torsades de poids, and torsades de poids is also known as polymorphic ventricular tachycardia. When you check their deep tendon reflexes, you will also see that they have hyperreflexia and they have altered level of consciousness, so they're also at risk for seizures. Okay, And risk factors, so if your patient has a lot of GI problems, because since magnesium is absorbed in the GI tract, you might notice low magnesium in their blood. If they're alcoholic, their mag tends to be lower, and if they're malnourished. Nursing management. So again, we're very, very concerned with cardiac. So you want to check the heart rate, blood pressure, 12-lead EKG. They are at risk for seizures, so you want to make sure you assess their level of consciousness and provide safety and assess their deep tendon reflexes. Now, when magnesium is low, make sure you check also the other electrolytes, especially potassium and calcium, because when magnesium is abnormal, it tends to affect also the potassium and the calcium level. Now, if the mag is low, you give mag, but before giving mag, you want to check the potassium level too, because there's a chance it will also be lower too. Okay? And remember, you have to teach them that, when they go home, they need to eat foods that are high in magnesium. And you will notice that foods that are high in magnesium are also high in potassium. Okay? So you pretty much telling them the same thing that you did on the health teaching for potassium. So we want to teach them properly so that we avoid readmission, okay, as much as possible. And for high magnesium level is, again, our focus would be cardiac. And yes, they will still have arrhythmias and seizures, but when it comes to reflexes, they have hyporeflexia. So patients who have this type of disease process are those patients who have end-stage renal failure, diabetic ketoacidosis, and patients who are receiving magnesium. So that's why when you're giving magnesium IV infusion, you just want to make sure that you monitor them closely. So as you can see here, when it comes to nursing interventions, we're pretty much doing the same thing. The only difference is the medications. So when medications come in on this type of patient, this time you want to give them calcium. Okay, it's an antidote for high magnesium. So you can also give, if your patient has a lot of fluids in their body and then they have high mag, you want to give them loop diuretics, but then again, remember, check intake and output and their kidney function. Now, if their kidney function is abnormal, then dialysis is an option for them. Okay? Now, if your patient is having fluid volume deficit with high magnesium, then you want to give them isotonic IV fluids.